So now the topic of discussion is about neck injuries. Neck injuries are again a unique type of injuries in which um, you can have a spectrum of injuries from a mild trauma to a significant vascular injuries and the tracheobronchial description. So the spectrum of neck injuries varies from a simple skin injuries to the musculoskeletal injuries and to the vascular and the tracheobronchial injuries. So it carries a very high spectrum of injuries, and there need to be an adequate protocol for approaching to a problem of neck injuries. Broadly, on orthopedic side, the injuries of the neck is classified into neck sprain, the simple neck pain. Then there is the injuries to the brachial plexus, the cervical cord, and the cervical spinous stenosis, cervical instability, and the cervical spine fracture, which is totally to be addressed in a separate entity. I'm concentrating only to the blunt injury to the neck as well as to the penetrating injury to the neck. So at the outset, I have to say that the neck has got a variety of organs. As you know, the trachea, the endocrine organ of the parathyroid and the thyroid, the main vascular structures which runs from the thorax to the neck and the brain. So it carries a higher risk of vascular injuries as well. And the airway pipe, the trachea, which traverses from the oral cavity to down into, or from the airway. What I meant was airway, which travels down to the lungs. So it is a complex area altogether. So for a practical description, the injuries to the neck by blunt or penetrating is described in the three zones. There are three zones in the neck. The zone 1 means it is from the suprasternal notch or just below the cricoid, that is zone 1. Zone 2 is from the cricoid to the level of the angle of mandible. If you draw a line at the angle of the mandible, that is the level 2. And the level 3 is from the angle of mandible to the base of skull. Those are the three levels. And these are important because each of the zones behaves in a different way, and you should be really wary whenever you find an injury in these zones because you may be tackling the problem without any knowledge or any protocol and finally land up in big trouble. Basically, whether it is a blunt or a penetrating trauma, if the patient is hemodynamically unstable and the patient is succumbing, there is no role for any investigation. You can rush the patient to theatre. That is for sure. Whether it is a penetrating trauma or a blunt trauma and the patient is exsanguinating or dying, patient is goes straight into the theatre. But the problem is patient who is not hemodynamically unstable but with the zonal injuries. Let us take zone 1. I'm just pointing to zone 1 because zone 1 is at the root of the neck. And what is important? It carries a trachea and it carries all the larger vessels in the form of the innominate vessels, the subclavian, the carotids, the brachiocephalic vein, and the conglomerates of the internal jugular, isn't it? So basically, they are very high caliber veins, high caliber arteries, the vascular and the airway tract. So whenever you approach these problems, the most important thing you have to assume that 1/3 of them are asymptomatic. And if you are not aware of the issues, then you directly go and explore. Without preparation, you will be in trouble. Right? So, coming to the zone 2. Zone 2 is as an advantage because zone 2 is an area where it is accessible. It is from the angle of the mandible with the cricoid. You also have all these vessels, the carotid, internal jugular, external jugulars, the trachea. But the advantage is here the accessibility to the proximal and the distal control is easy. So you are justified in exploring without an investigation at times. But ideally, they also should be investigated and the injury should be located or marked before you interfere. When you go to the zone 3, the importance is at the base of the skull. It's actually the real red zone where you may not be getting an access even properly. So, and these patients needs to be thoroughly explored, thoroughly investigated before you put a knife on the patient. So, broadly speaking, when you're suspecting a blunt neck injury and when there are hard signs, and that is hard signs of vascular and the surgical emphysema or hoarseness. If there are vascular signs, it's always ideal to do a CT angiogram and then explore. If there is a tracheobronchial injuries, always do a tracheal intubation and do a bronchoscopy. If it is a high risk pattern, if it's a high risk injury pattern, especially when the patient has got definite suspicious vascular injury, go for a CT angiogram, whichever be the zone. That is for blunt trauma. Now coming to the penetrating neck injury. Penetrating neck injury, as I said, if the patient is hemodynamically unstable, there is an expanding hematoma, if there is an excessive bleeding outside, and dysphonia, dysarthria, air leak from the wound, or if you have got a gross tracheal deviation showing that there is a retropharyngeal collection, then you have to explore straight. All zone injury, if the patients are hemodynamically unstable, then you explore it straight. But ideally, if the patient is hemodynamically stable, all the zonal injuries are better exposed with a 4-vessel angiography of the root of the neck and an arch of the aorta, followed by a barium swallow, so that you will know whether the esophagus is injured or not, and then take the patient to theatre. Or if there are no injuries, you can observe. So all depends upon hemodynamic instability and the patient's zone of injury. Only in zone 2, you are justified in exploring in a stable patient with a penetrating injury without a CT angiography. You got the point? Zone 1 and 3 are always approached in this regard. Now, what are the indications for a high-risk cerebrovascular injury whenever you have got a neck injury, blunt or penetrating? I have already quoted the entities. When there is an expanding hematoma, arterial hemorrhage from the neck, nose or mouth, focal neurological deficit, when there is a carotid bruit, when there is a stroke, or there is a neurological deficit, unexplained. That means that there is a definite cerebrovascular injury. Okay, and there are certain risk factors of facial fractures of Leaford 1, 2 and 3, basilar fractures, the cervical spine fracture, diffuse axonal injuries. These are also associated risk factors which determines your exposure and the stroke. Right. So, in summary, the neck penetrating injuries are called penetrating injuries when they penetrate the platysma. They are divided into 3 zones, zone 1, 2 and 3. If the patient is unstable, patient goes to theatre. The patient is stable, zone 1 and 3, ideally approached by 4-vessel angiography, CT angiogram of the arch of aorta and a barium swallow. If the patient is in zone 2 alone, you can think about a direct exploration. All other case, investigate and explore. This is a nutshell of, and depending upon the vascular injury, you decide on the side of approach. Like if it is a left subclavian vein, you go through the left side. If it is a carinal injury, you go to the midline median sternotomy. If it's a right-sided brachiocephalic injury, you go with the right side. Or depending upon whichever vessel is injured, you do approach in that way. Sometimes you will have to use vascular stents in case of the neck injuries. So that actually completes the management of neck injuries. Now coming to the next entity, that is the blast injuries and missile injuries. We are in an era of explosions, which can be some sort of a trivial explosions to very serious explosions in this war era and the terrorist era, right? So you as a practitioner have to be wary about a spectrum of injuries which is caused by the blast, right? It can be an ocular injury or an oral injury, pulmonary injury, cardiovascular, musculoskeletal, brain, and also the GIT, right? But you should have a basic idea. What are the types of blast injuries? You know the Newton's law. Newton's law says, according to Newton's law, the energy liberated is equal to mc square. and it matters on the detonating agent as well as the quantum of the detonating agent, the mass. So the energy will be directly proportional to the amount of the quantum as well as the type of explosive. It will not be same with a cracker blast or a blast with a when there is a terrorist explosions. They both are different. A dynamite blast or when there is an RDX blast. The blast effects are so different. And the blast is not just by the wave that is created. It is by the various other mechanisms. So as a clinician, you should be aware what are the types of the injuries the patient can succumb. Let us see what are they. The first one is called as the primary blast injury. That is generated by the blast wave which causes and hits the patient. Or it can get reflected from the back and give an antecedent hit also. Right? And they are more when it is in the air, water than in the air. Right? That is a primary injury. What is a secondary injury? Secondary injury, which I said earlier, was because of the fragments getting impaling into the body. That is the fragments injuries. Then comes the third wave, tertiary injury. What is tertiary wave? This will actually cause the propulsion of the body. Sometimes the blast wave will propel the body and body falls onto different places. That is a tertiary injury. Then quaternary injury is because of the environmental contamination, right, or by the burns. And there is the next level of injury is by whenever there is an absorption of the device materials that can compound to the injury. So the blast injury, it is a spectrum of injury from a primary spectrum or primary wave to a multiple effects by the various causes. And each of the effects will have effects on the various organ system. Let us see one by one. The most common structure that is injured is the eardrum or the ear. What are the injuries in the ear? It can cause rupture of the ear ossicles, that is a rupture of the eardrum through the pars flaccida, depending upon the decibel. Any decibel above 120 causes a eardrum rupture through pars flaccida. Right. Second thing is the rupture of or disruption of the ear ossicles. That will cause hemotympanum as well as middle ear deafness. The third injury is the cochlear damage or the cochlear cellular damage that will lead on to a sensory neural deafness. So in blast injuries, you will get a combination of the sensory neural deafness as well as the conductive deafness. And any blast which causes an explosive effect of more than 120 is likely to rupture the eardrum. And 140 is sure that it will rupture. So the minimal is 120 and 120 and above is always deleterious to the ear. Okay, what is the next injury? The killing injury in burns is the lung. And it causes the sudden expansion of the air containing alveoli. So what will happen? It will rupture an alveolo-capillary membrane and it will bleed. And what does it cause? It causes a heavy blast lung as well as there will be a decrease in the oxygen dissociation. Right? So whatever be the injury, that is the most common cause of death in a blast injury. The third injury is in the GIT organ and that affects the hollow viscus and the hollow viscus ruptures. And the sequence of hollow viscus rupture is always a doubt, but stomach, small intestine and the colon, because probably the stomach is the closest organ which will expand fast, that will rupture, but colon and ileum is also predisposed to the ruptures. Then comes fractures of the bones. Then the eye. Eye causes subconjunctival hemorrhages. It can cause lenticular disruption and naturally that will lead on to chemosis as well as that will lead on to loss of vision. Now coming to the blast injury in a stable patient or an unstable patient. Unstable patient, there is no doubt the patient has to be rapidly investigated and has to be taken for emergency surgery or emergency intubation. In a stable patient, always take an X-ray and a CT and do a vascular assessment And then all these patients are managed in an intensive care, support the ventilation, support the oxygenation, and if there is any deficit, take a decision based on the oxygen saturation and manage, and whatever surgical indication and the foreign body impairments have to be taken out with caution, with under all the scientific principles, and that is how you manage a blast injury. Now coming to the last entity, that is the missile injuries. Missile injuries are caused by either a low velocity missiles or a high velocity missiles injuries. And it can cause various effects, isn't it? It can cause it can actually go through the tissues with an entry wound and an exit wound, and it causes a cavitatory effect based on the resistance. So if you take abdomen, in abdomen, the missile injury commonly affects the solid organ, while we saw in blast injuries, they affects the hollow viscous. So the commonest solid organ injury is the liver or the spleen, which is injured by the bullet injuries, or that is what is called as the missile injuries. And it causes a bursting effects or a cavitating effects, either due to penetrating or perforation. So, and that affects the limb also. In the limbs, what happens? It causes lot of tissue destruction, tissue cavitation, and tissue necrosis. So the basic management is basically the same. You have to resuscitate, airway, breathing, circulation. But you have got a limb with a crush injury or a missile injury. Your problem is two reasons. There will be a vascular disruption, there will be neurological disruption, there is a musculoskeletal and fracture. What will you do? Idea is, at emergency scenario, it is the minimum. What are the steps to be done? The first thing is, you have to do an extensile exposure. That means you have to expose the area widely to a vital muscles or the tissues. Thoroughly debride all the dead tissues. You get the vascular control, and if the vessels are injured, it needs to be emergency repaired. Neurological bundles have to be identified and tagged and better avoided for an early repair. Tendon repairs are delayed and avoid to a later date. Bones, you can fix it with external fixators and do not remove any attached segments of the bones. You can remove unattached segment, destroyed and thrown out bones, but whichever has got some tissue attachment, better to be detained, and these patients should be kept as an open wound with an external fixator if the bone is injured, and continue dressing. And they have to be taken care in form of an hydration, and always think about a crush syndrome, because these patients will go for a crush syndrome and acute tubular necrosis. They have to be provided with the tetglobulin, as well as they have to be covered with strong antibiotics so that further infections and the multi-organ dysfunction is avoided. So thorough debridement, extensile exposure, thorough debridement, vascular repair, tagging neurological bundle, tendon, removal of the loose fragment, removal of all foreign bodies, but retaining the attached segments of the bone, and periodic dressing and revisiting is the key in success of the missile injuries. So this actually completes 3 vital topics. One is the neck injuries. Second topic I took was the blast injuries, and the third topic was the missile injuries. All the 3 are short notes, and practically also neck injuries are very vital, because you should basically know how to approach a neck injuries. Thank you.